How is it that we find ourselves surrounded by such complexity, such elegance?
The genes of you and me, the genes of you and me, are all made of DNA. We're all made of the same chemical DNA. We're all made of DNA. We're all made of the same.
Hi, you're listening to DNA Today, a podcast and radio show where we discover new advances in the world of genetics. From genetic technology like CRISPR to rare diseases to new research, we have you covered. For a decade, DNA Today has brought you the voices of leaders in genetics. I'm Kira Deneen. I'm a certified genetic counselor and your host. Non-invasive prenatal testing screening has been around for a decade now, as long as DNA Today, and the technology has evolved in those 10 years. The screening started to detect Down syndrome, and now Billion to One's Unity screen assesses for the chance for pregnancies to have aneuploidies, which are extra or missing chromosome conditions, recessive conditions like cystic fibrosis and sickle cell, and the presence of red blood cell fetal antigens. Billion to One named the screening Unity Screen as it brings together fetal screening for aneuploidies and recessive conditions. And it represents uniting pregnant patients in more equitable care. Unity does not require a blood sample from the other biological parent or sperm donor to assess fetal risk. This enables more pregnancies at risk to be affected with recessive conditions to be identified early in pregnancy as compared to traditional carrier screening. Billion to One is working towards one goal: to detect disease one molecule at a time. Know early with one simple blood test. Visit unityscreen.com for more information. And stay tuned for our upcoming episodes with Billion to One, exploring non-invasive prenatal screening for recessive conditions and red blood cell fetal antigens.
My guest today is Naseem Amin, the CEO of Orphalan, which develops and commercializes treatments for orphan rare diseases. In this episode, we're exploring Wilson's disease and their new FDA-approved treatment, which I'm learning has two names. Is that right, Naseem?
That's correct. Good morning, Kira.
Good morning.
Thank you for inviting me to talk to you today. And that is correct. It's in Europe, the product is called Cuvrior, and in the US, it's the same product, but it's called Cuvrior. And that was basically because in the US, the name could be confused with another drug. And so, and actually, Cuvrior is probably a more accurate name. We're a French company, and Cuvée is linked to a French word associated with copper. So Cuvrior is probably maybe a more apt name for the product.
Wow, we're only 1 minute in and I'm already learning. I love it. So to give a little bit of background on this, Wilson's disease is a metabolic condition, which for those that aren't familiar, that means that there's an abnormal chemical reaction in the body that disrupts a process. So for people with Wilson's disease, what is different about their biochemical process? You mentioned copper, so give us a little bit of the background on that.
Sure. So first, Wilson's disease is a very rare genetic disease. It affects about 1 in 30,000 of the population. And the underlying defect is there is a protein found in liver cells which chaperones excess copper out of the body through the bile and back into the intestine. In Wilson's disease, there's a mutation, genetic mutation, in that chaperone protein. And so, and there are over, I believe on the last record, 600 mutations that can occur in that disease. And there's a variety of phenotype that can be exhibited. But the underlying issue is that those patients cannot get rid of excess copper out of the body. So you and I in our diet on a daily basis may take, say, 3 to 5 milligrams of copper. We only need about 1 milligram of that. And it's a vital metal in many biochemical pathways. But when we shed the cells that have the copper in them, To replace that, we need about 1 milligram. The excess 4 to 5 milligrams in the diet needs to be eliminated by the body. And nature's has a pathway where whatever copper we absorb into the circulation, the excess copper is removed through this protein in the liver. So when you have a defect over time, the copper accumulates in the body. So it's comparable would be other like iron disorders like hemochromatosis, where and in this case it's just copper accumulates in the body. The first organ that often the symptoms and signs may occur is the liver, because the liver is the main organ for removing it. That's where it gets built up first, but it's also building up in many other tissues, and you can see it if you look carefully all over the body. And it's affected by how long it is before you're diagnosed. Sadly, even today, only 50% of patients are getting diagnosed. So there are a lot of patients out there who have Wilson's disease that they may not know, because the symptoms of the disease can mimic other diseases.
Yeah, a lot of rare diseases have that in common, that they're so underdiagnosed because people and healthcare providers not necessarily aware of this. They're thinking
Yeah.
horse, not zebra, something that we say a lot in rare diseases, where we're kind of flipping it and saying thanks to zebra. So you mentioned, with this diagnosis, there are over 600 different mutations, pathogenic variants that can lead to this disorder. Is genetic testing the only way that we're identifying Wilson's disease? Like, are there
That's
other
the
ways?
gold standard, but often it's diagnosed by a gastroenterologist, hepatologist. The patient may go in and they find abnormal liver function tests for some other reason, or because they have some symptoms, they end up seeing a gastroenterologist as part of their screening. They do liver function tests, they notice they're abnormal, then they start investigating. And if you end up and you're fortunate, you're seeing a hepatologist, they are all trained to know that Wilson's disease is one of the potential causes of liver damage. And, you know, sometimes you can pick it up because these patients develop a brown ring of copper in their eye, and if they have light color eyes, you can see this brown ring of copper. That's called Kaiser-Fleischer ring, and that's pretty much definitive. But many patients, you won't pick it up that way. You will do an extensive workup, but usually it's a combination of looking at how much copper is in the urine. They measure copper levels in the blood, and they eventually may, if some of those are abnormal, they can do a genetic test, and that will give them the definitive diagnosis: you have a mutation. Now, there may or may not, the symptoms may or may not be related. Um, there may be concurrent other problems, but a combination of the electrolyte, the blood test, the urine test, and the genetic test will give you the diagnosis.
And I think a key point for students listening, the Kaiser-Fleischer rings, that's like a board's question, definitely.
Exactly.
Yeah, because that's as you said, like a flagship symptom. Now, for like if someone has Wilson's disease and has for instance, like I have blue eyes, would you definitely see it in my eyes because they're light, or not necessarily?
Not necessarily. So it's like anything. The most patients are diagnosed in their teens, up to the age of 20s. The area we think that most patients may not be diagnosed is if they get neurological manifestations, because this neurological manifestations can mimic many other neurological and psychiatric conditions. And I remember I was hearing a very tragic story of a mother describing her daughter's journey. And, when she was a perfectly healthy girl up to the age of about 10, 12, then she started, you get into the teenage years, mood disorder, went to, people said this is teenage behavior. Then she ended up becoming more severe and seeing a psychiatrist who diagnosed depression. Then it went on to becoming almost like psychotic features. They diagnosed her as schizophrenic. Then she started getting movement disorders. Then someone said, "No, hold on, there's something more going on here." And the neurologist didn't even pick it up. And then eventually someone made the link, but sadly by then she was in a wheelchair. So,
Goodness.
this disease it progresses both based upon the genotype, but also the duration before you're diagnosed. And in the old days, before treatments were available, patients used to die in their early 20s. But since we've had treatments available since the 1960s, that has changed. But there is still a lot of disease burden. Many patients have liver damage, neurological damage. So we're either not picking them up early enough, or even if we're picking them up, we're not treating them. Compliance is a big problem with these patients because you take a lifetime of oral therapy 2 to 4 times a day, multiple pills. So there's a significant disease burden. And as you may know, teenagers, for social reasons, don't want to have to show everyone they're not well and taking medication. They often skip their medicines. So many of these chronic diseases face the same issues, and Wilson's disease is no exception.
Do you see this changing in terms of how many people are diagnosed? You've mentioned about 50% of people, it's estimated that, are actually diagnosed with Wilson's disease, so we're missing the other half. Do you see this changing with more people having expanded carrier screening? Like, I come from the prenatal realm, so that's something that Wilson's disease is on the carrier screening I'm ordering for people. So, I'm kind of imagining this next generation is going to be more diagnosed. We're going to see that 50% really raise.
Yes, and I hope so, because I think definitely, although like with many of these rare diseases, the epidemiology and the natural history is not well characterized. And that's one of the things we're trying to address. We've started a registry, which is an international registry, so we can track what are the problems with these patients. And you need to follow these patients many years to know that. But I strongly suspect the earlier you diagnose, and earlier you can intervene, the better the outcomes will be. So yes, my hope is the natural history of the disease will change with earlier diagnosis, and but that's going to take many years, many years, because
Decades, yeah.
decades and decades, because there are only a few hundred patients diagnosed every year. So maybe that will double, but we're talking about 400-500 patients, and you need to screen millions of newborns every year to do that. So it has to be part of a screening panel, and a few states and a few are doing that, but not many. So the more that do that, the better for these patients.
Yeah, to be able to have that just on newborn screening so that you're identifying that after birth and then they can be followed, and having that treatment early, as you mentioned,
Yeah.
is really key. So you're not building up issues in the liver and you're not having that accumulation of copper that you're like,
Yeah.
okay, we're really doing prevention and not even treatment at that point.
Yeah. Yeah.
To look at that. So, thinking about, as we've kind of mentioned, this is an autosomal recessive disorder. So,
Yeah.
both parents are obligate carriers. So they're both a carrier of the condition and passing down that copy of the gene that doesn't work.
Exactly.
So when we have this and someone is identified with Wilson's disease, who in the family should be tested to see if they also have Wilson's disease?
So obviously, consanguinity is a high problem. And in some countries, especially in the Middle East and island communities, you see a high rate. So often, if there is consanguinity in the family, you screen them all. And if a patient if you have one founder identified, then you should screen the family members. There should be genetic counseling. All those things are done. But because there are so many mutations, it is by nature more, actually, the prevalence seems to be more generally spread out similarly around the world, as opposed to maybe a single point mutation where it has more of a inherited pattern and is
Like
more
sickle
defined.
cell or
Sickle
something.
cell,
Yeah.
exactly.
Yeah.
Whereas this is more general. So I think the best chance and the most cost effective would be the prenatal, as you said, screening. You're only screening a few million patients per year, newborns per year. And although it's very rare, you're not just doing it for that disease, and that's how we'll pick it up.
Yeah, that's a really good point. And you've mentioned, I thought there was like 500 before this interview, but I'm learning there's over 600 mutations that have been identified so far. And just to mention, the gene is ATP7B.
That's right.
So, and you mentioned genotype. So genotype meaning like, okay, which mutation do you have? And then phenotype, what are the actual symptoms you have? Is
Mhm.
there any correlation between, okay, you have this mutation, we're expecting you to have this type of symptoms, or this is the severity of symptoms?
I think that I haven't seen it well characterized. There is some literature out there, but I would not want to speculate because, again, as you know, unless you have large population-based studies and you closely correlate the symptoms with and signs with a mutation, it is so heterogeneous that it would be probably not wise to try and define them. I think, but there are some that are more prevalent than the others. And then in geographies, there are differences. For instance, one of the countries, Costa Rica, has a very high prevalence rate. And they think there were a few founder Europeans who went over to Costa Rica a few 100 years ago. And, these remote communities, when it seemed to concentrate, and you see that a lot with these autosomal recessive genetic diseases, where you have closed communities where consanguinity will be high, interfamily marriages are higher, and then you get a concentration.
Yeah, that makes sense in terms of, where we're looking at, in the world of different areas that are more prevalent for Wilson's
Yeah.
disease. But it's, as you were saying too, like, okay, Costa Rica is one area, but it does affect many ethnicities. It's not
Oh,
necessarily
yes.
like other disorders like, say, Tay-Sachs. It's more concentrated in people that have Ashkenazi Jewish ancestry.
Exactly. Yeah.
Yeah, so I think that's another reason why, like, that's one reason why we should have it on newborn screening, because it's
No.
not concentrated towards certain people's backgrounds. It's
Yeah.
it's more of
Exactly.
like population
Yeah.
based
And it's
there.
interesting because one of the things we've been looking because we've been launching the product around the world, and we're in, we have filed for it for approval in China. And one of the things the Chinese regulators wanted to know was how prevalent is a disease. And it seems like from the literature, again, it's not the strongest evidence that the prevalence may be higher, maybe twice as high. Now, what is not clear to us is whether that is related to the underlying genetic prevalence of mutations or whether more patients may be getting diagnosed because their diet is high in copper. Patients, and secondarily, what we find is that they don't have all the current therapies available. So patients may be on suboptimal therapies, and so you might more likely pick them up. So these are some of the confounding effects to trying to understand. But what is striking about this disease is it is found everywhere around the world, wherever you look.
That's a really good point. I didn't even think some cultures may just have more copper in their diet, and then you're going to pick that up easier, whereas other places that maybe have that lower copper amount, and then you're like, okay, it's kind of underdiagnosed and everything. Yeah,
Yeah.
that's interesting.
If you've been listening to DNA Today for a while, you probably know I'm also a full-time prenatal genetic counselor. Between that job, this podcast, and being a producer, host of other podcasts, I'm pretty busy. So to keep up my energy and stay productive, I drink a decent amount of coffee. Think like Lorelai Gilmore, but maybe not quite that much. The new coffee I'm drinking is from Four Sigmatic, and I'm really picky about my coffee. It's got to be bold, not watery. That is the worst. I still drink it if I have to, but it's not my favorite. And I have to say, I've been really happy with Four Sigmatic. Here's the difference from other coffees. It includes mushrooms, which I know sounds bizarre. I will admit I was hesitant, but you don't taste the mushroom at all, and you get the health benefits from it. I like the immune system boost as I often get sick in the winter months, so this is really important. And I wanted to team up with Four Sigmatic to get you 30% off using promo code DNA Today, and you can redeem it at foursigmatic.com. Again, that's four, spell it out, F-O-U-R, Sigmatic, S-I-G-M-A-T-I-C.com. Use code DNA Today for 30% off, and let me know if you like it too. As a listener of DNA Today, you've probably heard me talk about NIPT, non-invasive prenatal screening or testing, that looks for extra or missing chromosome conditions during pregnancy. But did you know there's one that can also screen for recessive disorders like cystic fibrosis, sickle cell, and fetal antigens? Billion to One offers Unity screening, which does all of this from one blood draw from a pregnant person. Visit unityscreen.com for more information, and stay tuned for our upcoming episodes with Billion to One, exploring non-invasive prenatal screening for recessive conditions and red blood cell fetal antigens.
And so you're bringing up some of these treatment options, recommendations. Can you give us a lay of the land in terms of what the current standard is? And I also want people that are listening, if you're familiar with beta thalassemia, to kind of think about that too, because you mentioned that in the beginning in terms of treatment, there's a lot of similarities between it in terms of, in those, in beta thalassemia, we have too much iron. And so we're trying to get rid of iron in the body. And this, we're trying to get rid of copper. So there's a lot of parallels, especially for people studying for boards.
Exactly. So in this case, basically, it's a gradual accumulation. We don't have, for instance, like sickle cell crisis. It's a more gradual, insidious disease. But what happens is metal is a vital cofactor in many enzymatic intracellular reactions. Excess amounts of it will accumulate. So the body, copper in itself is highly toxic. So if I gave you an injection of copper sulfate, that would not be a good thing. So we take copper in the diet, and the main way it's chaperoned or protects the body is in the circulation. You have a protein called ceruloplasmin. That tightly binds the copper, and then that copper is considered inert. It's protected from injuring tissue. There's a non-ceruloplasmin bound copper, which is more freely available copper ions. It's either very loosely bound to some proteins or is free circulating. That is what is considered the level of that determines how much toxic exposure you've got of copper in the body. So the thing people measure is this, what we call non-ceruloplasmin bound copper. So it's the fraction which isn't bound to ceruloplasmin, which is inert. This is the non-inert. And that is considered to closely correlate with the body's tissue, excess copper levels in the tissue. You obviously can't measure the copper levels inside the cells in tissue, and because copper is diffusible, what you're measuring, the blood, should correlate to what's in the tissue. So the whole goal of treatment is to lower that level of non-ceruloplasmin bound copper. So the way we treat patients is when they're newly diagnosed, there's only one approved therapy for newly diagnosed patients around the world, and that's called D-penicillamine. D-penicillamine has historically been considered potent, but with a lot of side effects. Uh, anywhere from 20 to 40% of patients need to stop it because of some kind of acute side effects, and then there is also evidence over many, many years that it leads to additional complications. One of the things you see is the patients develop a very thickened skin, it can become gray, and it's believed that D-penicillamine causes inside the tissues itself, it causes a body reaction which is more gradual, insidious.
And is that the
So,
drug that you mentioned that came out in like the 60s? Like you said, treatment was
yeah, in
available in the 60s. Okay.
1950s.
Okay, 50s.
Um,
Wow. That's a
yeah,
long time in terms of like
that's a
having a
long,
treatment for a genetic disorder, a rare one.
yeah,
Like,
yeah,
wow.
exactly. So, and it was actually discovered by Professor Walsh, who sadly passed away last year. But he was the first person to identify a drug that could treat the disease. And what D-penicillamine does, it binds the copper in the blood, and then that complex is excreted through the kidney into the urine. So it's a way of bypassing the liver blockage, and now that complex is passed in the urine, and that's how you monitor the disease, how much copper is removed from the body in urine. The second treat, so if a patient becomes historically intolerant to D-penicillamine because of these side effects, they would try another drug called trientine. Trientine uh, uh, the molecule is trientine 2-HCl. That was historically considered much safer, but not very potent. So it was only reserved for second line therapy if you failed D-penicillamine. So our whole question was, could we develop a better trientine? We would like to think it's a better trientine. And could it replace penicillamine after you've acutely used D-penicillamine? So when the patient is decoppered, as they say, you remove the excess copper, but you want to maintain the copper levels constant in the body for a lifetime. And usually it takes, after you diagnose a patient, around 12 to 18 months to decopper them.
So that's a
And then
long
it's a
time.
that is a long time, but then it's a lifetime of maintenance. So what we did is we did a head-to-head trial with a novel form of the trientine, and we showed that you got the same amount of copper control, but without the well-known side effects of D-penicillamine, and that was the basis of our FDA approval. So what we showed is we're non-inferior. It was too short a trial to prove that we were safer, but we have 30 years of experience with these trientines that they have a safe profile. The innovation we came up with is that the existing trientines are unstable compounds. They need to be refrigerated product, and it's taken 2 to 4 times a day. So that a cold storage product taken 2 to 4 times a day is a problem.
I can see
The
now you mentioning teenagers having a hard time because they must have to go to the nurse's office to get that during the school
exactly,
day. Wow, yeah,
exactly.
that is
And
hard.
then the other challenges is that if you can't take it for 1 hour before a meal, and once you take it, you can't eat for another 2 hours. So there's a 3 hour period around them taking the drug. You can't eat.
And you're
Now, if
doing
you
this
have
2
to
to 4 times a day.
a
It's not
day,
just one a
exactly.
day. Wow,
So
that is
that's
very
six,
restrictive.
very restrictive. So compliance is a whole issue. So what we developed is a room temperature stable product. In our trial, we only gave it twice a day, and so we removed the compliance restriction of cold storage, and actually it's a small blister pack rather than a big egg sealed bottle. And we think that offers a convenience benefit which could translate into a compliance benefit. And those are the kind of studies that, which we are going to embark on. We are, we've just begun a pediatric trial. Uh, sorry, we have filed for approval with the FDA to do a pediatric trial, and hopefully either later this year or next year we can start that pediatric trial. And we're also looking at it in newly diagnosed children, so they would never have to go to depenicillamine if we showed therapeutic benefit with our drug. So we're trying to move earlier in the disease. So hopefully we would have the data in newly diagnosed and maintenance. So with a drug that has a long safe history in terms of safety.
So
So
if someone
that's
is diagnosed with this early, like let's say through like, they're a newborn or young child and they haven't had any symptoms from it and they're starting this medication, is it possible they could not have any symptoms from it if they're staying on this drug for the rest of their life? Like, are you
so
preventing the symptoms?
theoretically, yes, because the symptoms are, well, no one has done the trial. No one had ever done a trial comparing any therapy before we did one. So we were the first company to do a prospective randomized trial with any of the chelator therapies. What we have, what we do know after 1 year maintaining this copper level in a very tight range, that these patients did not progress, they did well. So if we were able to, and this is all now theoretical,
Right.
so I'm not making any claims or
Right. Just what
it,
we imagine and predict.
what we
Yeah.
imagine is if the patient had no symptoms, then if you treated them and were able to maintain their copper levels in a defined range, we have 1 year experience now that they should not deteriorate. So if they're asymptomatic and we get them early and we maintain the copper levels in this range, then we should theoretically prevent them ever getting the symptoms. Of
That's
course, these
powerful.
drugs, that will be very powerful. Um, and so I think the biggest contribution that we could make for Wilson disease is prenatal diagnosis. The second challenge that has actually existed is that, ironically, after almost 60 years of treating these patients, there is not a reliable blood test for measuring the non-ceruloplasmin bound copper. And that was one of the biggest challenges we faced to get our product approved. When we went to the FDA, we said, look, we would like to compare our drug to penicillamine. They said, well, how are you going to prove that? And we said, well, the obvious thing is to measure the blood levels of and non-ceruloplasmin bound copper. And they said, we agree with you theoretically, but there is no assay that we will accept for measuring that.
And they wouldn't accept looking at urine copper
So
levels?
that's a very good question. The problem is urine copper is it's a bit like looking at spot glucose levels. It urine can go up and down like a yo-yo, dependent on when you took your meal, did you take your meds or not? And the urine copper is very difficult to interpret for the following reasons. If I take my medicine, my urinary copper levels will be high because the drug is bound to the copper and that's what you're measuring in the urine. So you would say, that's great, I'm removing the copper. But patients, if they're not being compliant, and they often do, they take their meds the day before they came to the doctor because they don't want the doctor to pick up they haven't been
It's
compliant.
like flossing the day before you go to the dentist. Yeah.
Exactly. Then the copper levels shoot up. And you're actually trying to maintain them in a very constant range, 150 to around 500. If they come in with 1,000, you think, oh my God, this patient is really being overtreated, or there's so much copper in their body, they're removing, there's so much to being removed. But it may just be that they forgot to take their meds for a couple of days, they came in. And then if they're not taking their meds and they come in, there isn't any copper in the urine because it's not bound. And then you don't know, is it because they haven't taken their meds, or is it because I've depleted them so much there's no copper to remove? So urinary
Not
copper
very reliable.
it's not
Yeah,
very
see.
reliable. So that was the challenge we had. And in our pivotal trial, that's exactly what we saw. Before we randomized them to our therapy, or the urinary copper was going up and down like a yo-yo. But we were very fortunate because, we're a small, persistent company, and if it was make or break for us, we needed a reliable assay. So we actually worked with people who'd worked in the Alzheimer field, who had developed a very sensitive analytical method for measuring copper. But they hadn't applied it to Wilson disease, and they hadn't applied it to non-ceruloplasmin bound copper. After we validated our assay and presented it to the FDA, and the FDA said, this seems to be the best assay, enough that they allowed us to use that as our primary endpoint in our trial. And they have been encouraging us, and we are now trying to get that available as an approved laboratory-based diagnostic test, so we can offer it to physicians and as a assay, a monitoring tool for these patients. And because we did it in maintenance patients, we can only say this assay is reliable if you're stable and in this range. We haven't tested newly diagnosed, we haven't tested overtreated or undertreated, and we are about to embark on a real-world evidence study with that assay in the US, where we will look at these other populations and build on the data set. And we hope this assay, and it has the promise of becoming the standard of care diagnostic test for these patients for monitoring.
Wow, that's very exciting. You guys are really breaking ground in terms
We're
of
trying
treatment, diagnosis. I mean, this is fantastic. I wish we had even more time to talk about this. I've learned so much. Thank you so much for coming on the show, Naseem. I mean, there's just so much to learn about this disorder, and I'm just so glad you guys have put so much effort into this. And, just on behalf of the Wilson's disease community, thank you so much for spending your time and expertise in developing treatment and hopefully this diagnostic test as well. So thank you so much for coming on.
My pleasure. Thank you, Kira, for having us on. Thank you.
For more information about today's episode, visit dnapodcast.com, where you can also stream all episodes of the show. We encourage your questions, comments, guest pitches, and ideas. Send them all into info@dnapodcast.com. Search DNA Today on Twitter, Instagram, YouTube, Facebook, so you can connect with us there. And a favor, please rate and review the podcast on Apple, Spotify, or wherever you listen. This truly helps us climb the charts and allow more genetic nerds like yourself to find the show. DNA Today is hosted and produced by myself, Keir Deneen. Our social media lead is Corinne Merlino. Our video lead is Amanda Andrioli. Thanks for listening, and join us next time to discover new advances in the world of genetics.
The genes of you and me, the genes of you and me, are all made of DNA. We're all made of the same chemical DNA.